Welcome to a thought-provoking discussion on diagnostic error. My name is Dr. James Edwards. I'm an emergency physician at Royal Prince Alfred Hospital in Sydney and also the founder of On the Wards, a free open access medical education website for junior doctors. Today we'll be discussing diagnostic error, and this is an initiative of our partnership between On the Wards and Avant. And I have the pleasure of welcoming today Dr. Mark Graber. Welcome, Mark.
Good morning, James.
Mark is a leader in the field of patient safety in the United States. He's published widely in the area and has been a pioneer in efforts to address diagnostic error in medicine. I'm also joined by Dr. Owen Bradfield. Owen enjoyed university so much he's both a lawyer and a doctor and has been working in medical legal claims area with Avant Mutual for the past 6 years.
Good morning, James.
So to start, let's get an overview of diagnostic error. We're going to break this up into 5 sections: an overview of diagnostic error, decision-making and bias, preventing diagnostic error, responding to diagnostic error, and I guess learning and teaching about diagnostic error. But maybe to start, let's get an overview of what diagnostic error is and its impact on clinical practice. Mark, you said previously that diagnostic error has not yet had enough attention paid to it in the world of patient safety. Why is the concept of diagnostic error so important?
Yeah, thanks, James. Great to be here and talk to you about this. So let's start off talking about diagnosis. And diagnosis is important to you and me as a patient. If you're sick, you want your doctor to tell you what you have. You're not interested in uncertainty. You're not interested in hesitation or delays. You want to know what you have so you can get better. So it's important to patients, and it's very important to us as doctors because this is what we do. I'm an internist. Internists are supposed to be the guys who excel at diagnosis, so it's part of our image, and we want to do a good job with that. So diagnosis is important, but also diagnostic error is important because this is where you can be harmed. And there is way too much harm associated with diagnostic error today, and that's why we're having this discussion and hopefully discussing some things we can do about that.
Do you think you can give us a definition of what diagnostic error is?
Sure. There's actually 4 or 5 definitions floating around out there. The Institute of Medicine just published a beautiful report on this topic. It's kind of long. It's 450 pages, but it's everything we know about diagnostic error. And the definition that they provided is that it's a failure to provide an explanation of the patient's health problem and to communicate that to the patient. So that's the definition that we're all using at the present time. But basically, you're talking about a diagnosis that was wrong or missed or should have been made much earlier.
How common is it?
Yeah, well, been studied quite a bit in various ways. There's different kinds of research studies that have been done. So the ones I like the best are studies that have used standardized patients. So these are secret shoppers who go out into practices, and they have classic conditions. They have COPD, or they have rheumatoid arthritis. And you see how well the doctors do in practice, and they do pretty good. They get it right 90% of the time. They get it wrong 10% of the time, and this is for classic conditions. And there are many other kinds of studies, studies where you go back through patient records, surveys of patients and doctors, malpractice data, and we'll hear a little bit about that data from Owen. And you can triangulate all this information, and it pretty much shakes out to about that 10% number. 1 in 10 diagnoses is probably wrong. A lot of those won't matter. Thank God, the vast majority of diagnostic errors you get better anyway. The treatment I gave you worked, even though I didn't know exactly what you had. And that's great. Happy about that. But there's a very small fraction that does set you up for harm. And if you multiply that tiny fraction by the millions of diagnoses being made every day in our clinics and our ERs and our hospitals, that's where the harm adds up. And it is tens of thousands of people who die every year in America and comparable fraction in Australia from diagnostic error.
That's a fantastic overview to start with. Owen, can you give us an overview of maybe advanced data on the issue of diagnostic error?
Absolutely, James. So I guess it's quite an exciting time for Avant at the moment because we're just embarking on our claims coding project, and we've been able to code some data over the last few years. And what we've found is that there's over 700 claims between 2014 and 2017 that involve diagnostic error to some degree, whether that's misdiagnosis or delayed diagnosis. There's a few different ways that we've captured that through our claims coding. What we can also say is that about 10% of our claims portfolio claims, there was diagnostic error or misdiagnosis or delayed diagnosis comprised about 10% of our claims portfolio during that period. That's 10% by volume and about 25% by cost, so they're not insignificant. Unfortunately, what we can't say is what proportion of our claims, what proportion of diagnostic error rates there were, because we only see the claims where there's an allegation about the diagnosis being incorrect. So yeah, and in terms of the underlying causes for the diagnostic error, we've looked at a few different things such as, cognitive errors, misdiagnoses, delayed diagnoses, and then we've looked at whether those diagnoses relate to the initial assessment or with some degree of follow-up. And it actually goes down into quite fine detail what we've actually looked at, but we're still in the process of analysing some of that data. But it's really exciting, and we hope in the future that we'll be able to provide our members with a lot more detail about that, and be able to work in partnership with them and the medical profession as a whole to try and reduce the diagnostic error rate.
Yeah, just to follow up on that a little bit, it's a little different in the States. What's found in the large collections of malpractice claims is that diagnostic error is the number one reason for a claim in the States across multiple specialties, and accounts for the largest dollar per claim outlay. So big problem in both of our countries.
Have you identified a particular specialty groups that are a higher risk for having claims, especially in regard to diagnostic error?
Sure. I mean, I guess one of the things that struck me when I looked at some of that data is just the breadth of specialties that are affected by this problem of diagnostic error. It's certainly not a problem that is specific to radiologists or pathologists, as we would often think. Certainly radiologists are at the top. We looked at sort of over a 30-year career. At some point, 85% of radiologists will be affected in some way by a claim or complaint relating to diagnostic error. And certainly GPs make up another large, they make up a large proportion of claims as well, but that's because there's such a high number of members by volume. So many of our members are GPs.
Now, Mark, you mentioned that kind of 10% of diagnosis may be wrong, but I think most clinicians and medical practitioners will think they don't get 10% of their diagnoses wrong. How can you explain that disparity?
Yeah, big discrepancy there. And when I first got into this field, I couldn't believe that 10% number either. But as the years go by, I'm pretty sure it's right. And there are many reasons for that discrepancy. I think the biggest one is that we don't really get good feedback anymore on what happens with our patients. If one of our patients is really seriously injured or harmed or may die from a diagnostic error, I'm not going to hear about that. Patient may go to another hospital, they'll see another provider, they're not going to call me up and tell me what happened. And autopsies are disappearing from medicine internationally. And there was nothing like an autopsy to remind you of your fallibility. And we just don't get that kind of feedback anymore. And it's an interesting trick of the human mind. If you don't get feedback, you assume that you're right and that what you did was a good thing.
Yes.
So to the extent that we don't get feedback, we all think we're practicing at a very high level. And indeed we are. We do get it right 90% of the time, or 95. We don't really know what the number is. Nobody's actually measuring the rates in practice. But if we did get better feedback, if we were able to follow up with our patients more effectively, I think we would find that it's a much larger number than each of us appreciates.
In regard to, I guess, summing up some of the issues you've identified around diagnostic error, have you got any take-home messages?
Oh, there's many take-home messages. I think the big one is that these errors are common. We all know about it as physicians. We know about malpractice, but we assume that that's the other guy that's going to be affected. It's not me. And that's incorrect. We will all be, if you're in the practice of medicine, we will all be making these diagnostic errors on a fairly regular basis. So they're common, they're harmful, they're not generally well appreciated by physicians or even our healthcare organizations. Our healthcare organizations have so many things now just attracting their attention. They're worried about their finances and compliance and many other issues. It's just not the one or two thing on their radar screen. But we'd like it to be. We'd like there to be much more attention being placed on this.
I think we'll move to our next section, which is on decision-making and bias. Now, in regard to how clinicians think, there's that dichotomy between intuition versus that more analytical thinking when we describe how doctors make information processing. Now, we tend to require quite heavily, and I know I do as an emergency physician, on intuitive thinking, but maybe you can outline this concept of the dual processing model of clinical reasoning.
Yeah, sure, thanks. So there's been a lot of progress in this over the last decade or two by cognitive scientists and psychologists, and they've clarified how doctors think. And it's called the dual process paradigm. You've heard about it. And what's fun about this, it's the exact same way that we all think. So there's nothing special about the way that doctors think. Whenever, as a human, you're confronted with a new problem, there's a little center in your brain, the recognition center. It can be imaged on functional MRI, lights up, and most often you recognize what's going on and you know the answer. Or if you're a doctor, you know the diagnosis. And that's it. We practice in that mode a lot, more than half the time. So that's the intuitive mode, and it works really well, but it's problem prone and it predisposes to diagnostic error. If you don't recognize what's going on, you have to, what we call, stop and think.
Yes.
You know, you have to deliberately pause and reflect and rationally consider what's going on. And if you remember medical school, that's how we all started out, right? You don't know anything. So every problem it's so hard. You have to read about different things and think about all the possibilities. But with practice and experience, it becomes automatic, and we move into that intuitive mode. So I think a good analogy is learning a new sport or learning how to play a new musical instrument. You know, at the start, it's so hard. You have to concentrate, and it's difficult and stressful. But with time, it all becomes automatic, and you can just do these things without really thinking. So that's how we practice medicine, and that's how we get through our days. We practice a lot in this automatic mode. Every once in a while, we have to stop and think.
So when we consider senior doctors and junior doctors, do they think differently?
Well, certainly if you're very junior, you think very differently. You have to think about your pathophysiology and what you learned in anatomy and try and put it all together, which is a major challenge. But in practice, you recognize things. If a patient comes into my office in the middle of influenza season and they're febrile and they have muscle aches and a little headache, it doesn't take a lot of concentration for me to say, I think you have influenza. And odds are, overwhelmingly, that I'm going to be right. And it's like pattern recognition. I've seen that before. I recognize it, and that's how I make that diagnosis. So it's good in the sense that it's fast and it's effortless. Didn't require a lot of cognitive expenditure of energy. But the bad part is I didn't stop to think what else it could be. And for every presentation, there's other possibilities. You know, there's only, 200-300 presenting symptoms, but there are 10,000 diseases. So that same patient who comes in with fever and muscle aches and headache, sure, it could be influenza. It could also be Ebola infection, primary HIV infection, could be mononucleosis. There's 50 things it could be that I didn't think about when I intuitively walked into that influenza diagnosis.
So what are heuristics?
Well, heuristics, it's a fun word. It's kind of the fancy name for these intuitive things that go on in our brain. When these were first described 20 years ago, whatever, there were just a few. One was called availability, meaning it just springs into your mind. It's available for you to recall that diagnosis. Another one was representativeness, which means that what you're seeing in that patient has the same features as the classic condition. So, for example, in that patient with influenza, those are the classic features a patient would present with influenza. Time's gone by, and you can go to Wikipedia and find now 150 of these heuristics that are described, and more are being discovered every day. So there are all the little subconscious things going on that we're beginning to realize underlie all the actions that we take.
I mean, do they have a role in decision making, or are they something that we should avoid?
We couldn't get through our day if we didn't rely on these intuitive things.
So
you would just be stuck trying to figure out the first case. So it's essential that we rely on these things. But what we're hoping is that doctors will toggle back and forth effectively, and they'll think about how they came up with the diagnosis. And ideally, I mean, this is one of the interventions that we talk about a lot. We would like to see physicians always make a differential diagnosis. So makes you snap out of that intuitive mode and think what else it could be. That's kind of the universal question. What else could this be? Great advice for patients too. If you're seeing a doctor and he gives you a diagnosis, just say, what else could this be?
It's always difficult to make a diagnosis if you haven't actually thought of the diagnosis.
Exactly. Yeah, there's a famous paper by George Bordage, the medical educator. And I think the title is, Why Did I Miss the Diagnosis? And the number one reason, I just didn't think of it. So that's how we are as humans. When we're trying to solve a problem, a puzzle, the minute that we come up with a solution that explains all the little mysteries, we are happy. We're done. We're moving on. You know, life is short. I have 20 other patients to see today. I can't spend 4 hours on this one. So I like that diagnosis I came up with. There's actually a term for this. It's my favorite term these days. It's called satisficing. Satisficing. And it's a funny term, but it's the opposite of optimizing. So as medical decision makers, ideally, we would stop and think, and we'd construct that differential diagnosis, which we all learned how to do as medical students. But we don't do that when we get into practice. We satisfice. We are happy to accept the first diagnosis that comes to mind that seems to explain everything that we have.
Mark, I've got a question if I can.
Yeah, please.
I think our claims experience would sometimes show that very often when doctors come into problems with diagnostic error, it's when they've arrived at an initial diagnosis, they've started treating a patient for that initial diagnosis, the treatment doesn't seem to be working, and then there comes a point when perhaps that diagnosis might need to be re-explored and re-evaluated. Do you have any advice for doctors in that situation?
Yeah, thank you, Owen. Very, very important to point out that diagnosis is a process and it plays out over time. One of the, I think, major contributions of that report that we talked about from the Institute of Medicine is to describe diagnosis as a process. And, you know, illnesses evolve, and you may not be able to diagnose something accurately when it first presents because it's so nonspecific, it's so common. And it's only by watching how things play out and whether you do or don't respond to the initial treatment that you can finally figure out what's going on. So follow-up is just so important in trying to have high-quality diagnosis. Just a one-time visit is not the ideal way to do it. And that's one of the interventions that we recommend. We strongly believe that patients need to know how to get back to you and when to get back to you if their symptoms haven't resolved, or if they've worsened, or if they're not responding to treatment. And it gives you a chance to rethink the case, which is just great. It's how you would catch a lot of these problems.
Mark, another word that we hear a lot is bias, and we want to talk a bit about cognitive biases. What are they?
Yeah, so biases are the downside of all those 150 heuristics that we started talking about. So generally the heuristics are wonderful and they get us through our day, but each one has got a drawback. So for example, this recognition heuristic that we're talking about, it's great and it will be right, 90-95% of the time. But if you don't stop and make that differential diagnosis, you're going to miss things once in a while if a patient does present with something that's a little out of the ordinary. There are several of these biases that we see over and over. I think the most common is something we call premature closure, and it means you are kind of jumping to conclusions without considering other possibilities, that you're not making that differential diagnosis, and you're not considering what else it could be. Another very common one are context errors. So doctors are trying to make sense out of what's going on, and as humans, we're always trying to make sense out of our environments, and we do it really well. But every once in a while, we're just off, and we're in the wrong context. So, for example, we talked about that patient who was febrile and had muscle aches. So, okay, that sounds like a viral infection, and that we're in a viral context, we're in an infectious disease context. We're probably right, but there are other processes that can give you a fever. It could be a vasculitis, which is an inflammatory process, not so much an infectious problem. And we would miss that diagnosis if we stuck in that context of infections. And as humans, we're predisposed to do this. I don't know if it's ever happened to you. Have you ever gone to the movies and you come out afterwards to find your car in the big parking lot and you see it and you walk up to your car and you're doing the clicker and it won't unlock because you're at the wrong car.
Yes.
You're in the next row, but here's a car that looks like your car and it's the same make and model and color, but you mistook it for yours. And it's a context error, and we all do that. It just happens once in a while. Keep a little diary. You'll find these things happening every week for sure.
Owen, are there any other biases that you've identified within medical legal claims?
I don't know if it has a scientific term, but I think sometimes what I would sort of term a familiarity bias can sometimes come in, particularly where you have a long-standing relationship with a patient and, or perhaps you've gone down a diagnostic path and it's taken a lot of effort to, perhaps recall a patient, to undertake some tests, to get them back, to talk about it, and you're invested in that diagnosis. And I think to then, stop and take heed. What's really happening here is the diagnosis correct? So a little bit like what we were talking about before. I think I think the other issue as well, follow-up. I mean, that's so important, what you were talking about earlier, Mark. I think, again, a large part of our claims, particularly when it relates to delayed diagnosis, there is often, some issue or problem with the follow-up, and whether that's just a failure to have that initial discussion with the patient about what signs or symptoms to look out for if you're not improving, if your condition's not getting better, or if it's a problem with the follow-up system at the practice. So I'm talking in a general practice setting. It might be that